Welcome to the deep dive. This is where we take your sources, pull out the really critical bits, and basically give you a shortcut to getting up to speed. Today we're tackling what might seem like a very specific topic, equine rectal tears. Now, it's definitely a serious veterinary issue, but looking into it actually gives us some incredible insights into things like crisis management, rapid diagnostics, and, well, just how vital precise understanding is. Our mission here is to help you quickly get a handle on the complexities, the high stakes involved. You might be surprised just how intricate this subject really is.
Absolutely. And, while it's a very grave situation for the horses, the principles here, they tell you a lot about emergency medicine in general. We're talking split-second decisions, treatment strategies tailored to the exact problem. It's not just about veterinary practice. It's really about spotting subtle signs, understanding different levels of crisis, which I think makes it a pretty compelling deep dive.
Okay, so let's unpack that. Fundamentally, what is an equine rectal tear? We're talking about a tear, right? Partial or even full thickness in the wall of the horse's rectum. And you have to think about that wall as having layers, sort of like an onion. There's the inner lining, the mucosa,
Right.
then submucosa, then the muscle layers, the muscularis, and then that final outer layer, the serosa or adventitia. It depends on the exact spot.
And that's where the danger really comes in when those layers get compromised. As you tear through them, you go from something maybe manageable to something potentially catastrophic. And what's interesting is that most of these tears, they tend to run lengthwise, longitudinally, and they're often found dorsally on the top aspect of the rectum, usually somewhere between, say, 15 and 55 centimeters in from the anus. It seems to be a bit of a weak point.
Right. And the causes, this is where it gets really interesting for me. For such a specific and frankly severe injury, you'd expect maybe one big, obvious cause. But it's actually quite varied, isn't it? The one cause does stand out.
It really does. The most common cause, believe it or not, is iatrogenic.
Meaning induced by a veterinarian, typically during a rectal palpation. Now, that sounds bad, but it's usually not about carelessness. It can happen even with really careful technique. You have situations like the horse suddenly moving or straining hard.
Right.
Or those really forceful rectal contractions, we call them peristaltic waves. Maybe not enough lubrication was used.
Peristaltic waves, so those are the normal muscle contractions, just happening too strongly or at the wrong moment.
Exactly. They're the involuntary waves that move things along the gut. If they contract powerfully while the vet's hand is in there, or if the rectum isn't relaxed enough, that pressure can contribute to a tear. Other things factor in too, like if the rectal wall itself is already weak, maybe in older horses or horses with chronic issues or even previous trauma. And if the horse isn't properly relaxed, maybe not enough sedation or no epidural anesthetic was used, that increases risk. Plus, there are some inherent anatomical weak spots, like that dorsal area, about 25-30 centimeters in. It's still quite something that vet-induced is the most common, even with precautions. But what about other ways, outside the vet clinic?
Oh, definitely. Breeding accidents are another significant one. Either the stallion misdirects or sometimes during a difficult birth dystocia, the mare's straining or even manual assistance can cause a tear. Then you've got trauma from foreign bodies. Maybe the horse eats something sharp, like wire or bone fragments.
Oh, wow.
And it cuts the rectum on the way out. Less commonly, external trauma, maybe even bite wounds. And then there are rare cases of spontaneous rupture. This could be from things like ischemic necrosis, where the blood supply to the rectal wall gets cut off, or severe fecal impaction, maybe due to neurological problems causing pressure. And interestingly, horses with PPID, pituitary pars intermedia dysfunction, equine Cushing's disease, they can be more prone because the disease can affect tissue integrity, making things more fragile.
That's quite a list. So are there specific types of horses that are more susceptible, like known risk factors?
Yes, definitely. Besides underlying health issues, just having repeated rectal exams is a risk factor in itself. Signalment-wise, we tend to see it more often in Arabians, miniature horses, ponies, other smaller breeds, actually. Mares seem to be affected more often than stallions or geldings, and generally speaking, horses that aren't used to rectal exams are at higher risk.
Okay, so it's not just that a tear happens, but crucially, what kind of tear? This grading system seems absolutely central to everything. This is where I think you really see the precision needed in veterinary emergency med. Understanding the grade is decisive, right? It tells you the prognosis, the treatment plan.
Absolutely. It's the roadmap. This classification isn't just academic, it dictates the entire approach. Let's break them down. We need to look at what's torn, how you detect it, what it means immediately, and what signs you'd see. Each grade up drastically changes the outlook. So grade to 1, This is the least severe. It's just a tear in the innermost layers, the mucosa, maybe the submucosa. The key thing is the muscle layers underneath are intact. You might feel a bit of roughness during palpation, maybe a small defect. You'll usually see fresh blood on the glove afterward.
Okay.
But there's no connection to the abdominal cavity. Signs are minimal. Prognosis. Excellent. We're talking 93 to 100% survival. Think of it like a scrape.
Got it. So grade 2.
Grade 2 is different. Here, the muscular layers are torn, but, and this is crucial, the mucosa and submucosa above them are intact. So what happens is that intact inner lining can bulge or herniate out into the muscle defect, forming a kind of pocket or diverticulum. Because the lining isn't broken, you often don't see fresh blood, so it might actually be missed initially and found later, maybe incidentally. Still no direct link to the abdomen, but that pocket can cause problems later, like trapping feces or forming an abscess. Usually no signs of shock, maybe some mild intermittent colic. Prognosis is also excellent. Studies report 100% survival. It's like the inner tube is bulging through a weak spot in the tire wall, but it hasn't burst.
So almost a hidden risk that could cause trouble down the line. That makes sense.
Precisely. Now, grade third, this is where things get much, much more serious. With grade third, all the layers of the rectal wall are torn except for the very outermost layer, the serosa. Or, if it's in the part of the rectum not fully lined by peritoneum, the mesorectum.
Okay, hang on. Retroperitoneal portion, what's the significance of that? Is the mesorectum a different kind of barrier?
Good point. Retroperitoneal just means that part of the rectum isn't inside the main abdominal cavity lined by the peritoneum. So a tear there doesn't open directly into that main cavity. Instead, it opens into the surrounding fatty tissues, the mesorectum. So you still get fecal contamination, but it's initially contained within those tissues around the rectum, not spilling freely into the abdomen. And there are subtypes here. Grade third is where the tear goes up to the serosa, but the serosa itself holds, forming a fragile pocket. Grade third is where the tear goes into that fatty mesorectum, which is less effective at containing infection.
Wow.
The difference really is about that last, very fragile line of defense. Third has that thin serosal layer still holding back the tide, so to speak. Third tears into looser, fatty tissue, which offers less of a barrier.
So even within grade 3, there's this critical distinction based on that final tenuous layer. The level of detail is just incredible.
It has to be. Clinically, you'll feel a deep defect, often packed with feces. The horse rapidly shows signs of pain, systemic illness. It's very serious. High risk of abscesses forming around the rectum, cellulitis, and it can quickly progress to full-blown peritonitis if that last layer gives way. Signs you'll see: rapid onset of colic, high heart rate, sweating, depression, fever, signs of endotoxemia, that's toxins from bacteria getting into the bloodstream. Prognosis is guarded to poor. Survival rates are often quoted in the range of, say, 38 to 70%.
Okay, that's a huge jump in severity.
And that grade 4.
And then grade 4, the most severe. This is a full thickness tear where everything is perforated, including the serosa. There's now a direct, open communication between the inside of the rectum and the peritoneal cavity of the main abdomen. The vet might feel a sudden give during palpation, like falling into empty space. They might literally feel abdominal organs through the hole.
Oh my God. Gross fecal contamination pours into the abdomen immediately. It's an extremely grave emergency. Leads to severe septic peritonitis and rapid endotoxic shock. The horse shows signs of intense pain, profound shock, very high heart rate, rapid breathing, pale gums, often profuse sweating. They deteriorate incredibly fast. Prognosis is, well, it's grave. Survival rates are often cited as 0 to 2%. Sadly, many horses are euthanized at this stage.
That 0 to 2% for grade the 4th is just stark. It really underscores the severity. And this grading system, it just perfectly highlights how things escalate. From a relatively minor issue to an immediate life and death crisis, all based on which layer fails. It's fascinating how this level of detail, this classification, completely changes the game plan and the likely outcome. It really makes you think, doesn't it? In any complex situation, medicine, engineering, whatever, understanding the grade of the problem, not just that there is a problem, is everything.
It absolutely dictates every single next step. And because things can escalate so fast once a tear is even suspected, what happens next? What are the immediate crucial steps for the vet?
Right, the grading makes it feel like a ticking clock. What are those first signs, those initial red flags that scream, this could be a tear?
Well, during the rectal exam itself, feeling that sudden loss of resistance, maybe a definite rip feeling, or seeing a significant amount of fresh blood on the glove, those are immediate alarms.
Okay.
But sometimes it's not obvious right away. So high suspicion is also warranted if, say, after an exam or maybe after breeding, the horse suddenly develops severe colic signs, starts straining really hard. We call that tenesmus, develops a fever, or shows signs of shock within a few hours.
So it could be an instant uh-oh moment or more of a developing crisis. How do they confirm it quickly?
Exactly. So once suspicion is high, stabilization is paramount. First, sedation xylazine, dotamidine, but torphanol to calm the horse, stop the straining. Then, critically, a caudal epidural anesthetic. This numbs the back end and completely stops the straining reflex, which is vital for safely examining the area without causing more damage.
Makes sense.
Then, gently, manually removing feces from the rectum, especially cranial to the tear, helps visualization and reduces contamination. Sometimes drugs like buscopan are used to relax the rectum temporarily. For diagnosis and grading, once the horse is stable and the epidural is working, the vet will very carefully repalpate, this time often barehanded but well lubricated, to feel the tear's location, length, and depth. If available, endoscopy, putting a camera in, is ideal for actually seeing the tear and confirming the grade.
And checking for contamination in the abdomen.
Yes, that's vital. Abdominocentesis, taking a fluid sample from the belly. In grade 4, you'll see obvious fecal material, plant fibers, bacteria in that fluid. With grade 3, the fluid will show signs of inflammation, high white blood cell count, high protein, but usually not gross feces, at least not initially. Blood work, CBC, chemistry, fibrinogen, SAA, gives the bigger picture of inflammation, hydration, organ function. It's putting all the pieces together quickly.
It sounds incredibly intense, every second counting. What about immediate first aid? If you suspect a tear, what are the absolute must-do steps while trying to get to a referral hospital?
Okay, critical first aid for grade the 3rd or 4 suspects. Calm the horse sedation. Get that epidural in to stop straining. Crucially, stop more feces getting out. This means gently packing the rectum. You use something soft, like a stocking get, filled with cotton soaked in antiseptic, and place it cranial to the tear, packing backwards to block the hole.
Like a temporary plug.
Essentially, yes. And sometimes a temporary purse string suture is placed around the anus itself to help hold the pack in and reduce straining further, keeping it loose enough for gas to escape, though. Then, immediate high-dose, broad-spectrum antibiotics to 5 if possible. NSAIDs like Flunix and Meglumin for pain, inflammation, and to fight endotoxemia. Mineral oil or other softeners down a nasogastric tube to keep any incoming feces soft. 4 fluids for shock and hydration. And, absolutely critical, if you suspect grade the 3rd or 5, that horse needs to be transported to a surgical referral center immediately. Time is of the essence.
Okay, so they get to the referral center. The clock's still ticking. How does the treatment plan diverge based on the grade now? It's clearly not one size fits all.
No, definitely not. It's completely tailored. For grade 1 and 2, treatment is usually conservative, medical management. That means antibiotics for maybe 7 to 10 days, NSAIDs, keeping the manure soft with mineral oil or psyllium, feeding a soft, moist diet, and very importantly, avoiding any more rectal exams for about 10 to 14 days if you can. With grade 2, if that diverticulum, that pocket, causes ongoing issues like trapping feces, it might need surgical repair later. But generally for IN2, the prognosis is excellent with just medical support. It's about letting it heal.
Right, the less invasive route for the less severe tears. Makes sense.
Exactly. But grade 3, these are life-threatening. They need aggressive medical therapy. The antibiotics, NSAIDs, fluids we talked about, often a continuous epidural drip through a catheter. And meticulous management, like manually removing feces very frequently, maybe every 1-2 hours, to prevent pressure buildup. Rectal packing might also continue. Surgically, there are options. Sometimes primary suture repair is possible, working through the rectum itself. Other times, fecal diversion is needed. This might mean placing a temporary indwelling rectal liner, or TRL, basically a tube that bypasses feces over the tear site. Or a more major surgery, a loop colostomy, where a loop of the large colon is brought out to the skin surface to divert feces completely away from the rectum while it heals. Prognosis, as we said, guarded to poor.
That range of interventions for grade 3 alone is incredible. Really adaptive problem solving under immense pressure. And grade 4th, with that terrible prognosis. What's the approach if they even attempt treatment?
Yeah, for grade 4, it's extremely grave. Honestly, many horses are euthanized because the chances of survival are so low due to the overwhelming septic peritonitis. If treatment is attempted, it requires immediate aggressive surgery, a full exploratory laparotomy, opening the abdomen. The aims are to clean out the contamination as much as possible, surgically repair the hole in the rectum, debriding the edges first, and often this is combined with a temporary colostomy to divert feces. But even with all that, The survival rate remains desperately low, 0 to 2%. It really highlights the severity.
And assuming the horse makes it through surgery for a grade 3 or 4th, the journey isn't over, is it? The post-op care must be intense.
Oh, absolutely. It's a long road. Intensive postoperative care is crucial. We're talking long-term antibiotics, continued IV fluids, very careful dietary management with fecal softeners, ongoing pain control, and constant vigilant monitoring for complications like ongoing peritonitis, sepsis, abscesses, the formation of strictures or scar tissue that narrows the rectum, or even the tear breaking down again. Healing takes weeks, sometimes months. It's a huge commitment, which ultimately brings us back to prevention being the best strategy whenever possible. Proper handling, making sure horses are adequately sedated for procedures, using plenty of lubrication, and just meticulous, careful technique during any rectal exam.
This whole deep dive, it really hammers home how something seemingly so specific like equine rectal tears can teach us so much about broader principles. Rapid assessment, the importance of precise diagnosis, tailoring the response. It's a powerful case study in critical intervention. It shows how truly understanding the nuances, the different grades of a problem, can literally be the difference between life and death.
And that leaves a question for you, our listener, to think about. In whatever field you're in, how much more effective could you be if you really understood the different grades or nuances of a challenge instead of just seeing it as one big problem? And thinking about this specific case, what detail about how these horses are saved, or maybe why they sometimes can't be, stands out most surprisingly to you?
Yeah, something to reflect on. That power of detailed understanding in high-stakes situations, whether it's animal care or business or personal life, it really shows how knowing your subject, down to its very layers, can change everything.